Hello, dear friends. This is an update on the 17th ATTD convention from Florence in Italy. And I am Dr. Jothydev Kesavadev. It's very cool and calm weather over here. Sunny day. The temperature now is 14 degrees Celsius. And I am here to update you on technologies and treatments in diabetes, both type 1 and type 2. And this is day 1 of the conference. So let me start with some of the very important pivotal updates, and I'll be discussing on a couple of topics tonight. And let me start with the presentation by Dr. Davis, Melanie Davis, on the new era of managing type 2 diabetes. Of course, now it is a package. Diabetes comes along with obesity. And these are the basic principles of care as we have learned from the ADA, EASD protocols. So the ultimate objective of treating diabetes or obesity will be, number 1, to prevent complications. And number 2 will be to optimize the quality of life. And you have the following parameters over there, which includes the economic considerations, the complication surveillance, the health behavior modifications, the SDOH, which stands for social determinants of health. You have to address the psychosocial factors, and you may require technologies, because as a doctor or as a team member in a diabetes treatment team in the hospital, we alone will be insufficient to address all of these parameters, and you may require the assistance of technologies. And what are the effects of weight loss on comorbidities? Because I have started with something which is known to you, and then gradually I will move on to the newer modalities which we have discussed today. So when you are aiming at 5% weight loss, then you may be capable of reducing or eliminating the therapies for high blood pressure, and you may have probably the choice of reducing the dosages of some of the medicines for diabetes. And 5 to 10% again, prevention of diabetes, PCOD, and then when it is 10 to 15% weight loss, then it will have remarkable improvements in preventing cardiovascular disease, urinary stress incontinence disappears in obese people, metabolic dysfunction associated steatotic liver disease, obstructive sleep apnea, gastroesophageal reflux disease, the pain of osteoarthritis of the knee might disappear. And you will have probably diabetes remission in an overweight or an obese individual when we are successful in reaching more than 15% weight loss. And that is type 2 diabetes remission, HFpEF, CV mortality, and so on. So this slide is probably important. And this is something new. What are you doing now? As doctors and as diabetes educators or as dietitians in our team, we are aiming at the following parameters. We are providing diet advices, we are providing lifestyle modifications, and then we have a couple of drugs also now used for managing overweight and obesity. But there is a subgroup of people jumping, and that is for interventions which include the gastric bypass or banding and so on, which has been around for quite some time. And Melanie Davis discussed on this gap over there. And this gap need to be filled before the interventions. We will have the newer options on combination pharmacotherapy. And that is what we are going to discuss today. GLP-1. You know, gliflozins are not approved for managing obesity. They are for diabetes, cardiovascular, renal, heart failure, and so on. GLP-1 as a class, some of these medicines are approved for managing obesity and diabetes. And they are heterogeneous. They are not the same. Unlike the oral therapies, GLP-1s are not the same. There are small molecules such as semaglutide. There are larger molecules such as dulaglutide. And this is the basis of peptide chemistry. The medicinal peptide chemistry applied in a increasingly modular fashion, where you can have possible combinations of these amino acids and then creating peptides. And it is unlimited possibilities, intelligent assembly of modules, which can result in multifunctional molecular medicines with highly improved efficacy and allowing for targeted delivery, much more personalized management. Let me now discuss on the combination therapy. And we know the mechanisms of action of GLP-1. GLP-1 receptors are there in every tissue in the body, in the brain, in the heart, in the kidney. So it has got multiple modalities of action in different tissues. In the brain, it reduces the appetite, it reduces the food intake, but as a side effect, there is nausea. There are GI side effects. It increases insulin, it reduces glucagon, it slows the gastric emptying, it increases the lipolysis. And studies have shown, the pivotal clinical trials have shown, unravel the multiple merits of these molecules in cardioprotection, but it can result in slight increase in the heart rate, which is not problematic. Let me move on to the other molecule, and that is GIP. What are they? Because this is seldom discussed nowadays since these molecules are not available in our country. It also reduces the appetite, but it reduces the nausea. When it is combined with GLP-1, it reduces nausea. It also increases insulin, but increases glucagon. And it also reduces gastric acid secretion, increases lipid deposition, increases lipogenesis, it reduces bone resorption. So obviously, when GIP is combined with GLP-1, it will have multiple merits. It will have multiple complementary mechanisms of action. What about glucagon agonism? It again reduces appetite, it reduces food intake, but it can increase nausea. It increases insulin, no action on glucagon. And of course, it is a glucagon agonist, increases hepatic glucose production. It reduces hepatic lipid synthesis. That also reduces gastric emptying, increases the energy expenditure, and slight increase in the heart rate, similar to GLP-1. Remember, there is a reduction in the nausea with GIP. And these are the actions, the overall actions of enteropancreatic hormones on different organ systems. And you can see there are subtle differences. In the brain, GIP reduces nausea. And in the stomach, GIP reduces gastric acid secretion. In the white adipose tissue, GIP increases lipid buffering and lipogenesis. And in the kidney, you know, GLP-1, such as liraglutide, semaglutide, reduces albuminuria. It can increase natriuresis. And some of these mechanisms in the liver, so unique for glucagon agonism. Increase in the glyconeogenesis, increase in lipid oxidation, and increase in the heart rate. For all of these molecules, there is cardioprotection is currently proven for GLP-1. The others are going through the clinical trials. And for brown adipose tissue, glucagon and amylin increases the energy expenditure. So, of course, we are now having clinical experience with the semaglutide. Of course, tirzepatide is not available in our country. Semaglutide high dose oral is also not available in our country, 25 and 50 milligrams. In the clinical trials, it has completed the phase 3 clinical trials YSS, where the GI side effects were found to be similar, but with phenomenal benefits for both glucose and for weight reduction. And this is only tip of the iceberg. You have many molecules in the pipeline. You have orforglipron as an oral non-peptide GLP-1, cagrilintide, which is a combination of cagrilintide and semaglutide, once weekly injectable. You have mazdutide, you have survodutide, that is GLP-1 with glucagon, both of these. And then you have a triple agonist undergoing clinical trials, and these are the molecules in currently phase 3 clinical trials, and that is retatrutide. 4 to 12 milligrams, that is again going to be a once weekly injectable, and that is GLP-1, GIP, and glucagon agonism. So this is a overall view, I would say, is a bird's eye view of the molecules currently undergoing clinical trials. You have the GLP-1 injectable, which is already there in the market, and this is 7.2 milligrams once weekly. Oral ones high dose, we have only up to 14 milligrams oral currently commercially available, but ongoing clinical trials, Novo Nordisk 50 milligrams. Orforglipron, again from Lilly, and that is a non-peptide. Orforglipron, unlike oral semaglutide, there is no need of fasting, there is no need of ingesting it with half a glass of water, and no connection with food. It can be taken before meals or after meals. And then you have the GLP-1 GIP agonist. These are the dual agonists or twin cretins. The one which is available commercially, very popular globally, is tirzepatide or Manjaro. And then you have many others in the pipeline. For many other manufacturers, none of them are named molecules, amylin and agonists. So amyl agonist, cagrilintide, of course, the Novo Nordisk, and this is the one which is combined with once weekly semaglutide undergoing clinical trials, and peptide YY agonists such as N1, NNCO13. These are all only numbers and not named molecules in combination with once weekly semaglutide. And then you have survodutide from Boehringer Ingelheim undergoing clinical trials, and these are GLP-1 glucagon agonists. So you have GLP-1 and GIP agonist, you have GLP-1 glucagon agonist, and then you have triple agonist, and then you have oral GLP-1s. All of them undergoing the clinical trial. So the future is going to be completely flooded with the GLP-1 molecules, and this is the pipeline for the future obesity molecules. Semaglutide 50 milligrams orally, orforglipron, semaglutide high dose injectable. Currently, we have up to 2 milligrams, and this is 7.2 milligrams for once weekly injectable. Tirzepatide, the same up to 15 milligrams. Cagrilintide, and that is going to be a co-formulation of cagrilintide and semaglutide once weekly. Survodutide, mastutide, and then retatrutide, which is a triple agonist. What about the hemoglobin A1C reduction? Phenomenal reductions in the hemoglobin A1C when compared to the existing molecules and with weight loss. And this is where Dr. Melanie Davis addressed the gap. So these are going to be the newer molecules where the percentage weight loss is seen here. The proportion of people with more than 10% weight loss. Look at the numbers. The proportion of those with more than 10% or more than 15% weight loss is going to be phenomenal, with the newer molecules almost achieving close to the results of a bariatric surgery. So moving on to the launch of the next mission, and that is in type 2 diabetes. We have so many clinical trials, and I know that many of you, including myself, we are all part of many of these clinical trials: Triumph, Redefine, Cagrilintide, retatrutide, orforglipron, Dreams, Surpass with the same tirzepatide, Triumph 3, Achieve 5. So many of them, Of course, it is going to completely transform the way we treat obesity and type 2 diabetes. How can we ignore type 1 diabetes? The numbers of those with type 1 diabetes are also expanding. They are also increasing numbers. And today morning at Florence, at the ATTD, Boris Kovachev from the United States, he is one of the pioneers in artificial pancreas. And I have been referring to his original publications and his models and in algorithms for more than 20 years. And he discussed on neural net artificial pancreas. I'll briefly go through this because this is more technology oriented. And this is when success comes, when doctors are partnering with engineers. The neural net artificial pancreas. So we have been discussing about AID for more than 20 years, and now it is a reality. We are now in stage 4 of automation for artificial pancreas, which is now renamed as automated insulin delivery. A neural net artificial pancreas is an encoding of an AID algorithm into a neural network. You know that currently we have model predictive control, proportional integral derivative, and you have the fuzzy logic as the popular algorithms in the automated insulin delivery devices. in the automated insulin delivery devices. And here you have the objective to assess the NAP, that is neural net artificial pancreas. It is compared against the original UMPC in terms of glycemic outcomes. So the UVA model predictive control, so UVA it keeps on moving, that is the MPC algorithm. And 17 AD users with type 1 diabetes were recruited into the clinical trial. And this is something which is very important, but I will not go into the details. It is trained on either real people or in silico models. The neural network can approximate, it can automate the insulin dosing rule, and that can be to at any level of precision. Any level of precision is possible, generally depending on the network complexity. So this is the key basic concept of the saturated data set. And this is with the first NAP study, that is hybrid closed loop system. And this is the basic study demographics. Age of around 48 years with duration of type 2 diabetes of 26 years. Majority of them were females, and white, non-Hispanic 13, and 2 of them are blacks, and the glycated hemoglobin level of 6.8%. And these were control IQ users, and this is an IQ control algorithm in the tandem insulin pump. And these were the non-inferiority measures, NAP versus the UMPC algorithm for mean continuous glucose monitoring, for mean percent time below range, and there is below 54, in time above range, and so on. So almost all of these parameters were comparable between the two groups. And this is the CGM data, the daily profiles, no adverse events, and NAP versus the UMPC almost matching with each other. But when you are digging into the depths of the computational demands, there is a difference. Though they look the same, the two algorithms working simultaneously with almost exactly the same input. However, when you're using the neural network, it has 6-fold lower computational demands when compared to the UMPC. And this is the at-home study, a total of 36, 5-day in hotel, and then transition to 1-week home study. Meal and exercises not standardized at home, and no pre-meal boluses, bolus priming in charge, and remote monitored 24/7 with the automated notifications. And these are the first 6 participants, adults at UVA. And let me now discuss the results, because this is going to be a simplified report for the doctors listening to me, to make it very simplified. The adjusted time in range values, of course, exceeding the international recommendations, it is 86% versus 87%, almost comparable. There's 1% difference, that is 15 minutes difference, which is not statistically significant for TAR. And the broad conclusions are, this is a randomized crossover study. And it has found that the neural network implementation of a complicated MPC showed comparable performance. You know, the existing algorithms are highly complicated, and the recent machine learning approaches with the new neural network may be used in the AD space, because the AD space is now enlarging with more and more people using it. And NAPing is a process. NAPing is a process by which the action of any insulin dosing rule can be reproduced by the neural network. But the take-home message is 6-fold faster and requiring less computational demands. So the day has been very, very busy with a lot of things happening. And this is a technology-supported behavior intervention in type 2 diabetes. Again, addressing obesity, technology-supported behavior intervention in type 2 diabetes, coping with obesity using smartphone apps, connected pens. There are a lot of connected pens displayed in the exhibit as well, from the Novo Nordisk family, from the InPen family. The algorithms have now improved, and there is algorithm and connected pens for bolus and for the basal separate, but the bolus insulins are more popular for the connected insulin pens and for the smart insulin pens and for the caps. And the phenomenal advantage will be the avoidance, 43% avoidance of missed meal boluses when you're using a smart or a connected insulin pen. And so many new players in the space of closed loop systems and continuous glucose monitoring, because we were going around the exhibit stalls and we could see more than 10 new players for the continuous glucose monitoring system, some of them 15 days, some of them 10 days, 7 days. And the range of tools available within and for the future diabetes technology should address unmet clinical needs in type 2 diabetes. And there was also a discussion on the balance to be on microbiome in obesity and on preventing dementia, methods to avoid stroke and cerebral small vessel disease in patients, glucagon and GLP-1 agonists, treatments targeting amyloid proteins, potential treatments on targeting the immune system and boosting the neural repair mechanisms and so on. So the program and the convention is continuing in Florence, and there are multiple programs, events, discussions, and plenary sessions happening. It started from early morning onwards, and it is still continuing. I know the surprise continues, and there are so many innovations in diabetes, technologies, and treatments being discussed here. And this is definitely going to completely transform the way we treat diabetes. And I am so happy to be part of this. And thank you very much, organizers, for this opportunity. And good night, my dear friends in India, from Florence at the ATTD venue in Italy. Bye-bye.